It's great to be here. Thank you for asking me to speak. I'm very conscious in approaching this presentation today that it does say practitioner perspective, but it is very psychiatrist perspective. So it's a very complex area, and actually sitting down to think about how to cover in 10 minutes the tip of the iceberg, I think, was more challenging than I thought. But I'll do my best. The disclaimer I'm giving is really that I talk a lot about psychiatry and mental health services. I know that there's a lot of health and allied health professionals that are very much in this space as well. A bit about me is basically just to say that I did all of my medical and psychiatric training in Brisbane. I have worked in public mental health services for quite a while. I worked in the UK for 2 years in both as a consultant in general adult psychiatry, in their community mental health and inpatient mental health, and then in intellectual disability psychiatry for about 18 months. So I've been working with people with intellectual disability and mental health since 2004 now. And now I'm just at QSID. I have worked as a consultant in Brisbane as well. The reason I mention all of that is because it's easy for me on this side of the fence to say some of the things I'm going to be saying. I just want to say that I do know the enormous burden and strain that public mental health services are under. I know how hard it is for people without disability to get into public mental health services, and I know how hard it is for people to get treatment. However, just because you have an intellectual disability shouldn't mean you don't get to try. Who do I see? Just very quickly, I see people, adults with intellectual disability. Everybody who comes to me presents with challenging behaviour. That's significant because a lot of people are turned away from mental health services because it's deemed behavioural. But a vast majority have a major mental illness, and by major I mean schizophrenia, bipolar disorder. Why do I say that? Because that's the sort of disorders that have the best chance of getting services in public mental health. There's also an enormous amount of severe anxiety and depression that's harder to tease out in people with intellectual disability. Often people have tried and had some contact in the past with public and private mental health. Often they were followed up all through childhood by a paediatrician, and they turn 18 and have nowhere to go. So I'm being good and positive, so I thought about some positives first. And there have actually been positives. I've been working in this area for 10 years now, particularly the last 5 years. There's been a number of improvements. Some of those have been, planning for the future, but there has been an enormous increase in medical student numbers, but also in psychiatry training numbers that you can see there. Increased Medicare funding for telepsychiatry has meant that more people in rural and regional areas have a hope of being able to have more service. Because this is an area, psychiatry and intellectual disability is actually an area that works quite well with telepsychiatry and video conferencing. The special interest group Nick has mentioned, that's been very valuable on a number of levels. It's helped advocate so that intellectual disability psychiatry is now a competency in the new training scheme. It's helped the College of Psychiatrists advocate better for intellectual disability psychiatry. We've been very active at Congress every year and on a state level as well. And I think that it also contributed to things like the National Mental Health Roundtable coming into being. On a state level, I've come up with some improvements as well. I hope you're very proud. But I do, from a psychiatrist's point of view, the Carter inquiry and the restricted practice legislation has, I think, to me, at the coalface meant that more people are being prompted to have reviews of their Medicare. Now, the reviews may not always be ideal by any means, but I think that's an improvement. The dual disability coordinators Nick mentioned, and that has been an improvement. That's people employed and working within mental health service, generally part-time, allied health, nurse or psychologist, I think. There's still one in Metro South, which is Amanda Hendren. Metro North recently lost theirs. Townsville's been changed, and Cairns. A bit of the downside was that we lost our registrar in order to fund that, which wasn't our decision, but I'm being positive. The other thing this year is that Townsville is actually the first mental health service to have an ID mental health team. And that's been a very exciting development. It's very tiny. There's 0.1 of a psychiatrist and 0.1 of a registrar, but that's a big deal. That's a first in Queensland. So that's certainly an improvement. And the other thing is that we have a full-time registrar this year through the specialist training program. There is a shortfall in funding, so I don't know if we'll have it next year. But that makes 2.1 registrars total for the state out of 265 total trainees at the moment. So I tried really hard to make this simple and quick. To me, at the coalface, these would be my top 3 challenges. So the first is no news to anybody, but I just have to say, having worked in the area for 10 years, it's not getting any better from where I sit. And these reasons recur frequently. I'm going to try and just tell you a couple of stories to make it a bit more real from my clinical work. The first is the most complicated story, but this is Mohammed's not his real name and that's not his picture, but he's a refugee who came to Australia 3 years ago. He came to Australia already diagnosed with intellectual disability and psychotic depression, and he has reasonable verbal skills in English. He was seen at the major mental health service and refused follow-up. They did refer him to me, and he waited about 12 months at least to get in to see me. He has a pattern of stopping taking his medication. His mum doesn't speak English, his sister speaks some. When he's unwell, he becomes paranoid, hears voices and runs away. I think because he's been a refugee his whole life, he's actually pretty adept at transport and getting around in the community. And the short version of his story is that he's had admissions in Sydney, Canberra, Perth and Adelaide, all into mental health units, all with a diagnosis of exacerbation of psychosis. He has been refused. I fought with the disability coordinator and with disability services, and I have to say in this man, refugee mental health disability service case manager did a great job, and there was lots of hours of phone calls. But he was refused case management on 3 occasions. He's been taken back, he was begging, he's praying to God to kill him, and he still wasn't admitted. Actually, he said that in hospital. He asked to stay in hospital, and any of you ever want to get out of a mental health unit, that's what you say. Say you want to stay. And so he's currently missing. He is pretty good at looking after himself, but for obvious reasons, we don't know where he is, and anything could be happening out there. So that's his story. The reason I chose him to mention is because he has schizophrenia. If anyone was going to get into a public mental health service, if there was going to be any patient who was probably the most straightforward to understand and deal with, it would be this man. There are many others that are a lot more complex and need a lot more, but this, he's on a platter, really. So the hospital, he was, I knew the psychiatrist there, I know some of the staff there. You couldn't line up more things that it should work, really. So that was just an example for that. I think for me, the other big challenge in this area is expertise. Nick mentioned that we do a lot of teaching. I do a lot of teaching to disability services staff, but also to psychiatry trainees and at various stages of training. It's only that there's one lecture in third year psychiatry for 3 hours, and there is one lecture in the child program. There's probably a separate one on ADHD. So when I say a lot of teaching, we're lucky to get that slot, but the big thing for me, and the reason I put that Confucius quote, is that this teaching and training is great. And in the last 10 years, there are really good online training modules. There's a lot of training kits, there's talks, there's presentations at Congress. We're out there and there's things to hear. But to be honest, for a psychiatrist, and I think a lot of people, until you've worked, until you've had the experience, until you've got someone to model what good practice is, it doesn't make a lot of sense. You can read it in a book, but it's not the same thing. And I just wanted to point out on this point that in Brisbane, there's there's about 4 psychiatrists who will maybe not advertise, but are well known that they will see people with intellectual disability in the private sector. And all 3 of those were registrars who had registrar positions either with at Alston Park or at QSID. Actually, there's probably 5 actually, if you count public and private. All of those have translated to people who work actively in this area, which is a very high uptake. There are not many other specialties that people would do 6 months training and then go on and work in that area. So I think, if I was coming up with one thing, it would be about that training and that exposure. Having a registrar is a small, but that translates to a lot in clinical practice. And probably, I think I'll just mention the next quick case. This is quicker. James is an 18-year-old from a medical family. So I chose this man to talk about that because, again, if anyone was ever going to get good help, you would think it would be this man. He seriously has got 3 or 4 first-degree relatives who are doctors, specialist doctors. He presented having had a major regression in skills and his mental state over 2 to 3 years. He was practically mute when I saw him. He had been doing Special Olympics and all that sort of stuff at school. He'd been seen by 2 eminent private psychiatrists in Brisbane. One diagnosed him with late onset autism at the age of 16. The other one suggested dementia. Both of those conditions for non-medical people would be unheard of in a 16-year-old. And he was psychotic. He had probably an affective psychosis, but he improved really well on the appropriate medication and has done really well. He was really unwell for a few years and he has not got back to where he was. He's almost back to where he was, but I don't think he probably will ever get back to that point. But he can afford private follow-up. He's seeing one of those psychiatrists who work in the area and he's doing well. But it just exemplifies, I think, the complexities of this area at the coalface. The last one, really those first 2 were the big ones to me, and part of that is because the financial and reliance on private sector only becomes an issue if there's someone to see, really. If there's no one to see, then you don't get a bill. But I think in the current healthcare system, this is another issue. There is a lot of reliance on the private sector because people can't get in publicly. And there's a couple of psychiatrists in private practice who are happy with seeing people. There's a lot who struggle and who I will see for second opinions, but they don't want people referred. They see them because they've been referred and they're trying their best, but it's not ideal. And there's also the inherent nature of people with intellectual disability is that they're complex problems. There's a lot of paperwork. To do the job properly, there's a lot of paperwork. There's talking to family, carers, NGOs, agencies and things. And private practice really runs on Medicare. You are reimbursed for the time you spend with the patient, and it's impossible to have a practice in private psychiatry and operate like that without charging more. And the gaps are high. Some of them are very low, but they can be 150, 200, 250 easily. And particularly for people living at home with family, that's enormous. It's enormous for anybody, but it's an area where really that borderline mild group have not got a hope of long-term treatment with those prices. So the last case was really just a quick one about that. This was a girl who lived in regional Queensland with her parents, probably lower socioeconomic status, never been formally diagnosed with intellectual disability, was sticking razor blades in her legs, and seen by the local mental health service, diagnosed with personality disorder, behavioural, no service, not suitable for follow-up, was the wording I've seen the form. So I saw her. I did think she had an intellectual disability and her IQ was around 60, but she also, which I didn't do while she was severely depressed, but she had a severe depression that we did treat, and I think she probably got depressed because she went to school for 18 years and then had nothing. She's in that group where they where she wasn't eligible for funding for anything. She'd been thrown out of the 2 possible places in the regional centre she could have gone. So part of working with her was trying to help her family find some activity and some meaning in her life as well. So we did get her depression better, but it's still a rocky path getting there. So she couldn't. There's 1 or 2 private psychiatrists in that centre, and they couldn't afford to see them. So she gets scripts from her GP, but really should see a psychiatrist. And I tried to end on a hopeful note, and this was the best I could do.